Chairman, ladies and gentlemen, good afternoon. It is an honor for me to be here to present this presentation at this interesting postgraduate course. And I will share with you our experience and those reported in the literature in the treatment by radiofrequency ablation of early stage non-small cell lung cancer. Okay, this paper, the previous presenter, as I suspected, anticipate, and this is the background in which grew the need to develop further procedure, new treatment for those patients with stage 1 non-small cell lung cancer that are unsuitable for surgical resection. And together with stereotactic ablation therapy, radiofrequency ablation have been developed in the last 9 years. And it is a kind of thermal ablation, other source of energy utilized to induce thermal ablation of a soft tissue are laser, high-intensity ultrasound, microwaves. However, radiofrequency ablation is the most widely utilized and described in the literature. Even Hippocrates, thousands of years ago, stated that fire can cure those diseases that medicine and knife cannot cure. And this is almost how radiofrequency ablation it works. We apply the waves at radiofrequencies to a soft tissue, to a tumor. Radiofrequencies produce ionic agitation. Frictioning of ions produce tissue heating up to reach a coagulation necrosis of the tissue, the tumor itself. The first treatment by percutaneous radiofrequency ablation of a solid tumor was described in 1995 by Rossi and co-workers for an hepatocellular carcinoma. Then other authors reported their experience in the treatment of other solid tumors of other organs like prostate, kidney, breast, and others. Only in 2000 it was described by Damien Dupuy and co-workers the first percutaneous radiofrequency ablation of lung tumors. They reported the treatment with a palliative intent of 3 cases with advanced stage lung cancer, and after that first paper, many other papers appeared in the literature reporting their preliminary experiences. Here are summarized the most significant paper of this first period. And suddenly we have seen that radiofrequency ablation was effective. In the first experience with a short follow-up period, it was achieved even 91% of local control of the disease. Then increasing the follow-up period as it was expected, there was a decrease of the complete response rate, however, remaining at interesting and promising levels. Another aspect that we can understand from this table is that those authors like Herrera, Lee, and Jean, who treated greater lesions, obtained worst results. In fact, there is a limit to the volume of ablation that we can obtain with the radiofrequency ablation. At the beginning, in 1995, low-power output generator permitted to reach a volume of ablation of max 3 centimeters of diameter. Then in 2001, there has been a first evolution of the technology, and the high-power output generator and the needle with more deployable electrodes permitted to reach a volume of ablation up to 5-6 centimeters even if in 27 minutes. So it is not surprising if one of the main entry criteria is the size of the lesion. Actually, the most of authors do not treat lesions greater than 5 centimeters. But the main indication to this kind of treatment is a contraindication to surgical resection. Other entry criteria are the distance from great versus and Mayo Airway that must be greater than 1 centimeter and a platelet count of more than 50,000. The patient are prepared as for a myopulmonary resection before the treatment. Instead, the anesthesiology care is different. In the most of the cases, and in all cases in our experience, the procedure is performed under local anesthesia with a conscious sedation of the patient. CT guidance is the preferred and the most utilized guide to perform this procedure. It is possible to make a three-dimensional reconstruction for the correct placement of the needle into the tumor. But in selected cases, we can utilize also ultrasonography guidance when the tumor is in contact with the chest wall, with the parietal pleura. This is a more dynamic procedure, and it can be performed in the operating room, increasing safety for the patient. We utilized an high-power output generator, the Rita medical system, with 250 watts of max power output and needles with line deployable electrodes that open flow-like into the tumor from 3 to up to 5 centimeters according to the size of the lesion to be treated and so to the volume of ablation required. At the tip of 5 of these hooks of these electrodes, there are some thermistors that permit the continuous monitoring of the temperature during the entire procedure, which is maintained at 90 centigrade degrees. This happened until 2006. From 2000, since 2007, instead there has been another evolution of the technology, and now we utilize the microperfused multi-times system, which operate at 105 centigrade degrees, and permitted the same volume of ablation, but only in 9 minutes. Another important objective of the operator during thermal ablation is to try to encompass the neoplastic lesion with the thermal lesion at least 1 centimeter greater than the neoplastic one, like in this picture. Follow-up is performed mainly by CT scan, and radiological criteria to assess the response are the dimension of the lesion, the geometry of the lesion, and the contrast material enhancement. If the dimension of the lesions is, according to RECIST, the most important criteria, after radiofrequency ablation, at the first month follow-up, in some cases even after, the lesions may be greater, may appear greater, because we have tried to encompass, we have produced an ablation area greater than the tumor itself. So in this first period, the uptake of the contrast material is most important. We always performed the measurement of contrast material uptake before and after the procedure at each step of the follow-up. And when there is no uptake, or when the uptake is smaller than before radiofrequency ablation, it is considered a good response, and we move to the next step of the follow-up. We perform the CT scan at 1 month, 3 months, 6 months, and then every 6 months for 2 years. And after the first month, the dimensional criteria returned the main criteria, and as in these cases, in the complete ablation response, the lesions progressively shrink to a small fibrous scar. Even when we perform the procedure by ultrasonography guidance, then the follow-up is made by computer tomography. This is a significant case report in which we treated by radiofrequency ablation a paper with a single lung due to a previous pneumonectomy for lung cancer. After about 1 year, the patient developed a second lesion that, according to Martini and Melamed criteria, it was considered a second primary tumor. The site of the lesion probably would have required a right upper lobectomy, so we decided that radiofrequency ablation could be an option. We performed the procedure without complication, and at 6-month follow-up, the lesion in this case reduces, but not very much. So after contrast material injection, we observed no contrast material enhancement, and in this case, both the dimensional criteria and the contrast material enhancement criteria have been utilized to assess the response. This is our experience. Since 2001, we performed more than 200 radiofrequency ablation of lung tumors. 76 radiofrequency ablation have been performed in 55 stage 1 non-small cell lung cancer in 53 patients. 2 patients, in fact, have been treated for 2 separate lesions that, always according to Martini and Melamed criteria, have been considered 2 primary tumors. Clinical staging was stage 1A. This is the whole classification. Stage 1A in 43 cases and stage 1B in 12 cases. The mean diameter of the lesions was 2.6 centimeters. In all cases, we were successful in performing the treatment, in all cases with local anesthesia and sedation. The mean time of the procedure changed. Until 2006, it was 39 minutes. Then, from 2007, due to an increased experience in heating the noddle and, moreover, to the new technology we utilized, the mean time to perform radiofrequency ablation was 20 minutes. We recorded the mortality, and morbidity was almost 20%, with the pneumothorax the most represented complication, 9 pneumothorax in our experience, only 4 requiring pleural drainage. At a mean follow-up of almost 41 months, we recorded a complete ablation rate of almost 65%, a median time to progression of 36.8 months, and median overall cancer-specific survival of 34 months. Here are represented the Kaplan-Meier curves. On the left side, the overall survival. On the right side, the free progression survival comparing stage 1A and stage 1B lesions greater and smaller than 3 centimeters. In this case, there was a difference which was statistically significant. And here our experience is compared with 3 of the most significant papers reported in the literature. As you can see, the results in terms of progression-free rate overall survival and actuarial survival are comparable. In conclusion, we can say certainly that radiofrequency ablation is safe, of lung tumors is safe. Until since 2004, it was clear that it was safe. This is a study survey by Stank and co-worker in which they collected the data of safety from several centers in the world. We participate also to this study, and over 493 percutaneous procedures, only 2 deaths were reported. Radiofrequency ablation then seems not to damage significantly the pulmonary parenchyma. At least 2 papers reported that there is no change in the lung function test before and after the procedure. Now we can say that radiofrequency ablation seems to be effective even in the long term. However, recently other ablative local therapy like stereotactic ablation therapy have been utilized with very, very promising results. So I'm not sure of what will be the future role of radiofrequency ablation for the treatment of non-small cell lung cancer. What I'm sure is that radiofrequency ablation must be reserved to a patient unsuitable for surgical resection, and that surgery remain the gold standard of treatment for a patient with non-small cell lung cancer, even in the early stage. Thank you.
Thank you very much. I think we had excellent presentations, and I'm sure there are a lot of questions. Yes, Walter?
I have a question to Dr. Hassebeck. The stereotactic radiotherapy is an interesting technique, it's no doubt. I'm not surprised that the patients you are counseling are selecting this and not surgery when you show them operative pictures which look like from the slaughterhouse. You have
we don't have those pictures in our department hanging on the walls, but
yeah, you have
maybe
heard,
we should.
But you have heard presentations today from Dr. Walker, Dr. Asamura, and this is modern surgery. So be fair and balance it with modern.
I completely agree with you. That's why I said
surgery.
we would like to have randomized studies first, because
but you can
is
be
no
at least objective even before. But my question is, you showed us data that the local control is comparable to the surgical treated patients. I assume not all of these patients had histology or cytology. In the surgical group, all of them were proven lung cancer. Yeah. So how many patients were proven lung cancer in those you did radiotherapy? And you showed us that the local recurrence is the same.
Yeah, that highly depends on the series that you're looking at. Some authors have accepted only patients with histological proof of malignancy. In our case, we also accept patients who have growing lesions who are PET positive. So in our series, about 40% of patients had proven malignancies and 60% had not. We've also looked at the difference, and there's no difference between patients who had histological proof and patients who didn't.
Is it really 40%? One of your colleagues recently said 30%.
In our current series of 500 patients, it's 40%. It used to be lower in our older series, but that percentage has gone up now. We've also treated more and more patients with large tumors, more central tumors, and they have a higher percentage of histological proof. So it's now up a little bit.
I agree with you that we should do randomized studies, but I think thoracic surgeons should be involved when you design those studies. And even in Roselle's study that was mentioned, histology is not required to enter the study. So, and what you do with the patients, you open up and you don't have histology, they will go out of the study. Another point is, what is the primary endpoint in the study? And when you look at the study, the primary endpoint is local recurrence. But there's no good definition of local recurrence after radiotherapy, because you have some radiation fibrosis and pneumonitis around the lesion. So when you look at the literature, there's no definition after radiotherapy of what is local control of local response. So that's a major issue. Another thing is, as you stated, there's no lymph node dissection, so we don't know which patients will have adjuvant therapy. Yeah. And another point is that I think it's also important that for central lesions, as stated in literature, you have much higher toxicity than what you stated. You did not mention that, but you have a very low toxicity for peripheral lesions, but for more centrally located lesions, up to 50% of the patients have toxicity.
Yeah. First of all, those patients are excluded for the Roselle study. Only peripheral patients are included in that study.
But you should mention that. It's to an audience.
Yeah, there's much debate about central lesions. Like I showed you, we are now treating central lesions with another fractionation schedule that's much more forgiving if you look at toxicity. The Timmerman paper that you're referring to used very high fractionation, very high fractions, really inside the mediastinum. He's shown pictures on the Astro that he treated tumors really inside the mediastinum, overlapping with, for instance, the esophagus. And we're not saying that you should do that. I think that's very dangerous.
Yes. So in Roselle study, I discussed it with Dr. Lagerwart also. When you have so-called local control, for which there's no good criterion, when a patient dies of distant metastasis, it's a success of the study. And I wonder when this is really a success for the patient.
You are more than invited to do a better study, to make a better study. We will participate.
No, but when you design a trial, so you should involve thoracic surgeons, not reverse. I cannot design a trial on radiation therapy.
I think surgeons were included in the protocol, but...
Yeah, after it was designed.
Okay, more questions? I think there are 2 points that should be addressed by the presenters. One is, according to your ideas, what is the definition of non-operable patient? Because in one of the slides presented by Dr. Ambrogi, I've seen people having up to 3 liters of preoperative FEV1. So if you would like to go on the podium, please, maybe you could answer something. And the second question maybe could be answered by Dr. Asamura and Dr. Rami. Minimal resection, of course, I suppose, should be preceded by frozen biopsy of lymph nodes. Maybe this could be an additional question.
The criteria for inoperability of the patient, it is not also lung function test, but also other comorbidities like cardiac comorbidity, and also the age and the general status, performance status of the patient, together with the lung function test, defined inoperable patients in our experience.
Well, sorry, the problem is that it has been demonstrated that lobectomy can improve pulmonary function in COPD patients. So I'm not sure. I think the definition of inoperability should be addressed.
Yeah, another things to say to say that those lung function tests were not performed also only in patients who underwent radiofrequency ablation for stage 1 non-small cell lung cancer, but in all patients of our study, and in those reported in the other paper. So patient even with lung metastasis, for example.
You have a question related to this? Or?
Related to stereotactic.
We first let Dr. Samura answer on the frozen section. Yes.
Yes. In performing the minimal surgeries in diminishing the extent of lymph node dissection as well as lung parenchyma, the role of intraoperative assessment of lymph node is more and more important. In our practice, we are doing a lobectomy with lobe-specific lymph node dissection. We usually make 3 or 4 lymph nodes as a frozen section. So in also segmentectomy, I think intraoperative assessment of hilar nodes and some mediastinal nodes might be indispensable. So diminishing the extent of dissection, I think the intraoperative assessment of lymph nodes are more and more important, and it should be done.
There's another question on radiotherapy. Yeah.
Yes, Thanos Joris from Finland. I have a question. I think one of the problems with the 95 Ginsberg lung cancer study group study was that there were non-anatomical resections included in the series, and the survival advantage was against the non-anatomical resection. Now, I think this might be a surgical equivalent of the stereotactic radiotherapy. I'm absolutely convinced it has its indications. It sounds fantastic, but if you would compare it to patients who may have a radical operation, lobectomy, or anatomical segmentectomy, which is a radical procedure like Professor Samura is presenting, how can you really compare? Is it acceptable to compare these procedures?
We always say that we have the very high dose exactly where the tumor is. That doesn't mean that in the surrounding area the dose is 0. In the area, for instance, for the first few centimeters around the tumor, the dose is still much higher than for conventional radiation. So maybe, we're doing more than just a very local excision. That would be one of the possible explanations for the local control.
So would it extend beyond the limits which Professor Asamura was showing, comparing a radical segmentectomy up to the hilar level of the lobe, or where would the radiation effect stop? I don't know.
This depends on the technique, but it's more or less around the tumor. It's not in one direction. It's around dose distribution. And I'm not a surgeon, so it's difficult for me to compare the techniques.
Thank you.
Now the problem is when you carefully look at that removed specimen, sometimes you have lymphatic or vascular invasion, even for smaller tumors. And the question was, could you control that with radiotherapy also?
Microscopic invasion we can control as long as it's not very long distance from the tumor. On the other hand, we've also had some patients that we expected to have local failure, growing lesions. We did a lobectomy after all, and there was only scar tissue. So you can go in 2 directions.
Okay, another question?
Well, thank you very much for organising this. I think it's so important to discuss these issues. I just want to start off by making a comment. I've always been very concerned about the 1995 paper by Dr. Ginsberg, because we've heard some criticisms of it, but the other 2 criticisms that we haven't reminded ourselves of today was that, first of all, 495 patients were randomised, but not actually for some reason included in the study when it actually came to intraoperative randomization, and also middle lobe tumours were excluded. So using that paper as the only RCT to guide us as to lobectomy being the type of anatomical resection we want to be doing for appropriate cases of lung cancer, I think is dubious, and it's not relevant to current practice. So the other issue in this is, what is the type of surgical resection that can be most widely applied to early stage lung cancer, sub 2 centimetre lesions? And I think if one looks at the wide databases from different countries, it's probably large wedge resections with an appropriate margin. And I think margin is the key issue in here. And I think it's very important that you have made these presentations today, because in the next 5 years. I see the same sort of thing that's happened in cardiology and cardiac surgery happening. Stereotactic radiotherapy is going to be driven by industry, patient preference, and enthusiasts. So I think we need to have a trial of those two modalities run relatively soon. I'm concerned that if we're talking about a trial of videoscopic lobectomy against stereotactic radiotherapy, we will have suboptimal recruitment, which is a problem in all of those studies. Now, what does the community think of that? Or should we have a registry to try and guide us?
Of course, a definitive answer can only come from a randomized trial, but are we really ready to perform a randomized trial? There are so many questions that remain we cannot answer for the moment.
Well,
I stated.
I'm going to make a very controversial statement now. Randomized controlled trials don't help us for two reasons. One is they even out sampling problems, and secondly, they ensure matching. Now, if you have a registry that actually has a very high rate of accrual from a given population, and you change the question, you can actually answer more. So instead of saying, what is the best treatment, stereotactic radiotherapy or VATS lobectomy, for example, you say, what is the best treatment in this group of 70 to 80-year-olds with this range of lung function? And otherwise, we're going to have numerous trials with poor recruitment, as is happening.
But when you really think about it, it becomes very difficult. So, for example, you randomize a patient with a PET-positive lesion, you open it up, and it's a tuberculoma, so it's infection. You remove the lesion. When you do intention to treat analysis, you follow up the patient. But of course, he will have a good survival and no local recurrence. Is that correct? Or would you eliminate that patient?
That is correct, but I think you have to eliminate that patient. Mm-hmm.
And those patients we operate with positive lymph nodes, would you not give them adjuvant chemotherapy? Because we discussed with radiation oncologists, they said we are not able to give chemotherapy because we don't know anything about the lymph nodes. Would you think it's ethical to do that?
No, I don't think it's ethical.
No, but you have to think about when you design a randomized trial.
Well, this is why I'm saying that maybe...
It's not just saying we start a randomized trial.
Maybe this is... What I'm saying is maybe the randomized control trial is not the best way to get the answer in this situation.
I hear that Dr. Ross at the MD Anderson is already performing randomized trial between SRT and the surgery. I would like to wait the result of Dr. Ross's study. And with regard to the randomization, I think in part I agree with you. If we have some registry data, it will provide us some suggestions. But as Paul says, if we like to clearly get some answers, I think we still need randomized trial.
And another point is that we are also afraid of insurance companies. In a few years, they will be looking at this data also, and they will see the results, and the manager will compare those results, and they will just say, well, SRT is cheaper, and we won't have randomized data by then. That's another issue. Yes. If we will do a randomized trial, I think we have to do it now.
Other questions? Dr. Walker, can I ask you about the recent review that was published in the Journal of Clinical Oncology presented at ASCO? Indeed, there was a survival benefit for those patients having a VATS procedure, but when they looked at the pure VATS patients, so no large utility thoracotomy, the survival benefit disappeared. But there's no specific reason stated for that. Do you have an explanation for that? Was it just coincidence?
I think the non-pure were about 40% of the total, if I remember correctly, so perhaps there would be an effect of numbers. I think the thing, as I said before, that struck me most about all these random meta-analyses was the substrate that they were working from was really not a very good reflection of what we could offer surgically when we report our data. It ought to be the same thing comes from every center, and then you can add it all up much better. So I can't immediately explain that, but it's not consistent with the Whitson or Cheng studies, and the Yang one isn't consistent in a couple of other areas too. So I imagine it must be something to do with how they selected their patient sets. You could also argue, that all of them are a bit damaged by the fact that many of the series they include go back the full 17 years, so they are quite old data they use as well.
Before closing, I would like to thank to all the participants and panelists, and Paul has a last announcement.
And especially Dr. Haasbeek for coming to a surgical audience. And I have another announcement, especially for the women, those who know women in thoracic surgery. Tomorrow there's a specific meeting of meeting women in cardiothoracic surgery, organized by Calliope Anastasiadi, but men are allowed in that session. Okay. I have some flyers for those who are interested.
No way.